anything. My husband is a surgeon, so please, surgeons, I'm not here. You know, I mean, he's a pediatric heart surgeon, so please, but these are things I've been practicing as a doctor in Ghana this is my 31 years, so I've seen a lot, and especially when I was in Kolibu, because of what I was doing, a lot of the feedback, both from patients and family. So you get to hear a lot of things. So wrong size surgeries, retained surgical items, organ nerve. We'll look at it more in detail. Sorry. So wrong size surgery. It's in the name. Surgery on the wrong body parts or patient. My friend is here. Obeka said, "Missy orthopedics," but you know it is true. So we have a general surgeon here. We have a gynecologist. Oh, and all three of them are sitting together. I'm in trouble. It's good I don't work in raging car. But it is reported commonly, wrong side surgery is reported more commonly in orthopedic surgery, general surgery, and gynecological surgeries, and they are all sitting here. So I didn't plan this. But I mean, sometimes, okay, so there was this incident where a woman was supposed to have evaluation under anesthesia and ends up having a salpingectomy done. Darkoff versus Kolibu was a very interesting case. I don't know whether you remember that this was a young guy, you remember that case? Yes, who had an injury on I think it was the right knee tendon, and he was supposed to have it corrected. The left knee was done. Later, I went to go. The interesting thing, and we have a judge here. In fact, when I read that judgment, I'm like, are you serious? He said that it's like he had given a general consent. I come to hospital with injury. This is where you're supposed to operate. You end up operating this one. I take you to court, and the judge said, I think the judge also made a point that the patient's lawyer did not do a good job of proving the case. So the hospital was not found liable, even though wrong surgery was done. What they were found liable is that because the boy and the family decided to take them to court, they ignored the boy, so they wouldn't look after him. So that was what. Please, after the end of the day, I want to understand this. This judgment here. Okay. But these things happen because of absent checklists, site marking errors. If the site had been marked, and you know that there are many more that we are not talking about here, especially in your specialty. Retain surgical items, that one, from surgical tools to gauze or sponges inside patients. It leads to infection, and that is when it comes to reoperations and pain. It is underreported, but we know that it does happen. So how do we check it? Surgical counts, checklists, radio pictures. I think one time I was watching Grey's Anatomy, and they were doing the count, and they had counted and counted and counted, and there was still one gauze missing. And this guy said they've looked everywhere in the abdomen. Bailey was doing the sage, nothing. But she said, I am not closing up. We're finding it. Until somebody was walking and said, oh, the gauze is under your Crocs. But I was surprised by how long she was prepared to wait and find that extra thing. So please, it has a very interesting name. So this article is in 2013 by Dakubu and Naida. They looked at cases at Kolibu, and 12 cases were found between 2003 and 2012. And some of them caused bowel obstruction, abscess, prolonged this thing. So the picture, so if you look at the picture, if you can see it, this one is gauze. So this was a thyroidectomy. The person had a goiter. They removed the thyroid, but then they left the gauze in, But there are risk factors. In emergency surgeries, you are in a hurry. You quickly want to do what you're doing and get away. Poor hand over, sometimes we not even then sponge count. I mean, I'm hoping that when the discussion comes, the 3 people who are notorious for doing that would address some of these issues. Organ injury. You can have surgery and there can be accidental, is it accidental or incidental? Probably incidental. But sometimes, depending, let's say you are operating on the abdomen, and I use myself as an example. I've had 6 abdominal surgeries. So if you go and there are adhesions all over and it takes a long time for your wound to heal, you cannot blame the surgeon. It's because of the so that is not iatrogenic. That one, there's a reason why. But sometimes in some surgeries, again, it's the same 3. Gynecological, bowel is done by the general surgeon, orthopedic surgeries. These it's the spaces they work in. So they know I'm not picking on them. They know that this is in the literature, that is why it's like that. And again, some of the risk factors, sometimes there's inexperience. Hopefully you would have a supervisor and that is it. But some of the surgeries, there's such poor visualization and our theater lights are not always great. I mean, well, in my facility, you see, it's fairly new. So, but the other thing too is that you need to quickly get whatever is there out to save the patient's life. And I think if you have to choose between a complication and death, a lot of surgeons would rather go for that. At least a complication, hopefully you can deal with it. If you take your time and you want to do it like you are doing an elective surgery and tying everything, cauterizing everything, it may not help. So these are risk factors that happen. So this is a study that was done by Ali and some of our colleagues in UHAS, where they looked at ureteric injuries during abdominal and pelvic surgeries between 2015 and 2021. So there were 12 patients and they had 19 iatrogenic ureteric injuries, mainly due to hysterectomy. 83.3% of the ureteric injuries were due to the gynecologist. Okay, no, let me not say gynecologist because they did find out that a lot of the surgeries were not done by specialists. So it's not gynecologist. So, but it was mainly due to hysterectomy. In the districts, I mean, you don't have specialists. Maybe it's changing now. Cesarean section and even hernia repairs. And often they were undetected intraoperatively. If you detect it intraoperatively, you can get it sorted out, but it's not. And the cause was that the surgeries were done by non-specialists. So again, it's important that we have specialist supervision. The same thing with bladder injuries, where people had bladder surgery. So this was 2 patients in Kumasi, also in the literature, where they retained suture and catheter fragments. It led to recurrent UTIs over several weeks before they found it, and the cause was incomplete inspection post-procedure. If you're doing surgery, you know the process that you go through. So how can we prevent surgical injuries? Supervision by specialists during high-risk surgeries is key. When Dr. Yinsu was speaking, she said that in the US, she, as the attendant, gets there before her residents. I don't know, here I know that some attendants get to work early, but others too come late. When you come late and you are not able to supervise, then it becomes critical, especially if it is high-risk surgeries. Prior planning and imaging is also important. In fact, now imaging is not an issue. It's more about an affordability. But before, I mean, when I was in medical school, 93, 94, there was no CT scan in Ghana. So if maybe your lecturer asked you a question and then investigations, you mention CT scan, you are in trouble. So in 93, I go to Belfast for my electives. I was working in a clinic and they were asking what investigations I would do. And I mentioned everything, but not CT scan. They said, what about CT scan? I said, oh, sorry, in Ghana, we don't have CT scan. So if I had said CT scan, I would have been in big trouble. And they all burst out laughing because there it was there. But now CT scan is all over, so many private places for us to do that. So it is key that we do. Surgical safety checks are important. You know the thing, you know your hurdles, you know before procedure, in procedure, and after procedure. Surgical site infections. This is another study done by Bedi Akumbuwan and others in Kolibu that found out that they looked at this 358 abdominal surgeries done in Kolibu, and they found infections in 16%. And what they actually found was that it was linked to high OR door traffic and poor aseptic conditions. You know, depending on the facility, there's nothing like you being in theater and just people in and out, in and out, in and out, and they are supposed to be aseptic when they come in, but they are not. So we have to be mindful who we allow in during surgeries. These days, there are cameras, there are TVs, there are other things that we can use to do that. Prevention of iatrogenic harm. So what can we do? So one of the reasons why we are having this, and I know last year you had it, is to promote a culture of safety and transparency. We need to do regular training on ethical care and communication. A lot of the issues that come up, you know, even when medical errors have occurred, the way you handle it can determine how the patient responds. If the patient sues, it's one thing. If the patient doesn't sue, and especially in the US, when there's an error, you've gone through the process, you've done your risk analysis, you've done the apology, you've done everything, and the patient still goes ahead and sue. What's the thing that the judges give? What should be the compensation you will give is far less than if you hadn't put in any restitution measures. So it's important that we do that. The mitigating factors are very, very important. But sometimes, you see, I'll share an experience I had. It was something that I was dazed because I was a house officer when it happened. A patient had come for chemotherapy. There was extravasation. Instead of the chemo going through the veins, it went into the limbs, and the limb became enlarged. And the senior surgeon took the time, explained everything, apologized, and asked what they could do. All that woman wanted was her bill to be waived off. They went to see the CEO at that time. So I'm talking 95. The CEO at that time, 95, 96. And the person said, no, the woman should pay her bill. Of course, the woman paid her bill. Then she went to Shraj and got a huge set. I mean, how can you do that as an institution? It is your error. The woman is not asking for anything. All she wanted was write off her bill. How much was that bill? But the head of the institution said no, and it cost them. So please, we need to be mindful about how to. We've heard a lot about empowering patients to participate in their care. Policymakers, they are right here in front of me. Institutional Care Division. As for the policies, I know we have them, but we need to implement and enforce the guidelines on patient safety. Support independent ethics and safety committees. Emphasis on independent. Now there are a lot more bioethicists. I mean, even though I work in Kolibu, I get consults from other hospitals and things, and then I encourage others just to have a committee. We train them. They look at these things. Legal recourse and compensation. Don't wait for the patient to go to court. When you know something has gone wrong, talk to your lawyer. At least UGMC, the staff do very well. I mean, they will readily call Frank, and if it's something that involves me, he will also call me, and we'll see how to do it. Because when you are proactive, the outcome is better than you wait and then it becomes then. When there are oversights institutions, we need to make sure that the civil society and advocacy. We heard a lot from Dr. Yensu. Raising awareness on patients' rights. As I said, where I work, UGMC, the patients, they know their rights. I mean, they know more than their rights if it is possible. But for most other facilities, they don't. So every facility should have a patient advocacy unit where they advocate for patients. It is critical to have that if we want, because at the end of the day, when the patients are happy, we are happy. But if the patients are not happy, then we get into trouble. So advocate for safe and dignified care. Don't treat people anyhow. Treat them with dignity. I mean, sometimes the things I've seen, look, you don't know what the person is going through. They've entered your consulting room. There's a bad odor, and you, as a nurse, a doctor, pharmacist, you are holding your nose. That is so unprofessional. How long is the person going to stay with you? You chose this profession. You chose. You don't know what they've been. You don't know where they are coming from. So treat people with dignity. If you were the person, isn't that what you would want? Support victims of medical harm and foster dialogue. Foster dialogue. Once you do that, do this. So actually, I put this here because I saw that the minister was supposed to be here. That was why. But since minister is not here, but Ghana Health Service, you are the implementers. Ministry policies you are here. So please, we need to lead a national strategy on safety. I said, I know it's already there, but we want to, but we want it to be national, so that every facility knows that this is what we are doing as a nation, not this is what UGMC is doing, this is what Kolebu is doing, this is what Kofu Anochi, this is what Rich is doing. We need to fund training in clinical ethics and safe practices. I mean, for doctors, we are required to do ethics CPD at least once every 3 years. I don't know for the others. I did something for the pharmacists last year, so they probably do that. I hope the nurses, but these are things that we do, because if we know how to practice ethically, we'll do that. Monitor iatrogenic incidents, okay. Then champion reforms that prioritize human dignity. I'm skipping this. These are questions that we would ask, but a call to action. That's what I'll end on. Because it's as if he had seen some of the things I was going to talk about. Several of the things he raised were things I had put there. So, call to action: preventing iatrogenic harm in Ghana. Establish and implement national reporting systems for medical errors. Do we have that? As far as I'm concerned, I don't know, but maybe the patient safety team, I really hope we have that. If we have that, we should be made aware. Support patient safety education for healthcare providers and patients. You can do it. There are several levels. Some would even become champion black belts. It is there. Sponsor people to do that, so that at least in any major hospital, we have people doing that. Introduce mandatory patient identity and procedure verification protocols. I hope that every patient in every hospital in Ghana has a name band. I know it is not real. I know that even in UGMC, where I thought it was happening all the time, there were times it was not, and we only found out when errors occurred. So please, patient bands, until the patient has walked out and sat in his car, they are still your patients. Adopt digital tools, empower advocacy and legal protection frameworks, encourage interdisciplinary ethical review of adverse events. When things go wrong, it's not because surgery did this. We all need to do that. Bring the surgeon, bring the nurse, pharmacist, psychologist, bioethicist, social worker, if you have a chaplain or anything. And let's do that. I think if we are able to do this together, we can prevent avoidable harm and build a safer ethical health system. Thank you.